we have got a fantastic panel. We've got Dr. Pramit Patel, who's a former chair of the Primary Care Network. He's a trustee of the NHS Confederation, runs a fantastic GP Fed in Surrey Heartlands. We've got Caroline Taylor, who's chair of the National Association of Primary Care. I'm not doing this in order. I'm reading it from here. I'm not very I've got to an age where I'm just not very adaptable, really. I just stick to my script. We've got Camilla Hawthorne, chair of the Royal College of GPs. I'm getting back into order now. And then we've got Samira Anand. Have I got your surname right? No.
Anand.
Samira Anand, who's deputy chair of GPC. It was supposed to be, as you know, Katie Bramwell-Stoney, but we're really pleased, Samira, that you've stepped in. And then last but not least, we've got Amanda Doyle, National Director of Primary and Community Care in NHS England. So I'm going to ask a few questions because there's 5 of you and we don't have that much time. I know you're going to be really pithy. And I'm going to throw the script in the air because I'm going to start with you, Amanda, because now we have to be careful about how we talk about this. There is likely to be an announcement of some importance occurring at some point quite soon, maybe even today. And I wonder whether, Amanda, you could kind of, without breaking any kind of parliamentary rules or anything like that, you could tell us what we might be wanting to hope for from the announcement that we might hear later today about something that we can't absolutely confirm. But it's clearly being announced today because it's the Confed Primary Care Network Conference, and we're very grateful for the government bringing more publicity to our event. Amanda.
Thank you. That was clearly a trap. I can't talk in any detail about the 24-25 contract because we haven't yet published it. We are hoping to publish it very, very soon. I would hate to spoil anybody's possible bedtime reading over the next few days of a very interesting and long letter from me. But what I can talk about is what we've tried to do, and so what we hope to do in for 24-25, but also to set us up for what we need to do for the future. So a lot of this people have heard me say before. This is a stepping stone year. We have 1 year of funding, so there's no possibility of having something which replicates the 5-year deal we've just been through. People may or may not be pleased about that. So we've got a stepping stone year. What we've tried to do is recognise the financial position is tight, and so some of the more fundamental reform that people are calling for becomes quite difficult to do. But what we've aimed to do with this contract for next year is take us in the direction that we would be aiming to head for when we do look at more fundamental reform. And the things that we have, and we've talked to a lot of people, a lot of stakeholders, including this network, including the college and the BMA and patient groups and a huge number of stakeholders to sort of listen to what everybody's saying about it. And what we have aimed to do is to continue the streamlining and the reduction of bureaucracy. So further streamlining of incentives so that there is less bureaucracy, while not trying to presuppose the outcome of the public consultation on incentives in primary care, which is going on at the moment and which closes next week. So we'll be looking to make some changes to streamline things further, make things simpler for practices, make things less bureaucratic. But the big change, if there is any, around incentives will be dependent on whatever the outcomes of the consultation are, and that'll be for next year and future years. But we have made some moves around that, and you'll see that. We are conscious we published the Access Recovery Plan last May. It was a 2-year plan. It had big asks for practices around, not targets to hit, but big asks around things to do to change the operating model, to implement change, to put quite a lot of work into focus on access and modes of access. So we're not looking to add additional burden as far as that goes. We're looking for people to continue to embed that and to, by the end of this month, next month, by the end of March, we should have all but literally 1 or 2 practices in the country with proper telephony systems with the functionality that people need for a modern model of general practice access. We want to embed how that's used appropriately and how people use the data to support managing their demand, but also look at how that data is used to help us with being able to evidence the size of the demand on general practice. Because I sit in meetings all winter every morning and they tell me numbers of people sat in ambulances at every bit of the country, number of people waiting in A&E for beds and how long they've been there. And they say, what's demand like in general practice? It's very, very busy. We actually need evidence to demonstrate the sheer volume of work that is being dealt with and to support the need for something to enable us to escalate when that demand becomes difficult to manage. So get people, giving the people the space to actually use that data properly and embed the work they're already doing. PCNs, we want to continue to support PCNs and we have aimed to do that. But we also recognise that we've come to the end of the initial 5 years and actually PCNs are up and running and increasingly, and there's a range of maturity, but increasingly delivering services at scale in quite a different way to their populations. So we want to give PCNs more autonomy, more flexibility, and the ability to use the funding that comes into the PCN as they see fit to deliver for their local population. So what we have aimed to do is be much, much less prescriptive about how you run your PCN and what it does. And you'll see some of that detail should we publish quite soon. The additional role scheme, again, we started it 5 years ago with the aim of moving the bulk of general practice from being a largely GP and practice nurse service to being a service that can be delivered through a multidisciplinary team under the leadership of the qualified GP, but not everything delivered by the GP. That has been hugely successful. We well overachieved on our target numbers of additional staff. We overachieved a year early, really successful. We actually want to be much less prescriptive about how people do that. So the commitment to continue to invest is there, support for PCNs and their teams is there, increasing the flexibility on who and how you can employ people is one of the aims. How many things have I talked about? Money. The
NHS... an audible murmur when you said that.
The NHS financial position as a whole for 24-25 is incredibly tight, and that is playing out not just across what we're able to do for primary care, but also across the whole, every sector. Recognising it is tight, and I also recognise the particular pressures that puts on practices, and as we know, primary care just cannot and never does go into deficit. Recognising the pressure, I can do no more than distribute the total financial envelope that is available, but we have tried to take steps to both increase the flexibility around how that flows, but also tried to look at ways in which we could improve cash flow for practices by doing that. Is that enough from me?
That's great. That's great.
Happy to answer questions on it, but I can't give out the detail. But as I say, the detailed information is coming really soon.
So, thanks, Amanda. So, Samira, if you, in a hypothetical world, had seen this document and been involved in talking about it and were able to comment on it, even though we don't know what exactly it's going to be and when exactly it's going to be published, what would you say?
I think, well, I'll just repeat what we've said in the discussions with NHS England and the Department of Health. We are very keen that this year is a stepping stone year, that it gives hope, it gives stability, and it gives safety. And those are really three key principles that we're very committed to having instilled. And we've been very clear that people can make choices. They can make choices around resourcing. They can make choices around decisions that may not have any net increase in resourcing. And we can only suggest and negotiate and input. So we're really keen to work collaboratively We're very solution focused in the fact that we understand that general practice and primary care are part of a wider system. We don't work in silos, and therefore any solutions really need to fit in within the wider system. And the benefits with the patient at the core, benefits to the nation in terms of the economic modelling. I'm very glad that Amanda's mentioned the zero deficit that primary care has contributed when we look at the ICS deficits that we've got. So that's what I would say. And I think we're still committed. We're still committed going forwards. We've got an election year, and we'd like to work collaboratively with all the stakeholders to ensure that we've got a really sustainable, positive future that all of us can look forward to being part of, and remaining for our patients.
Great, thank you. And Camilla, do you want to kind of respond to what you've heard?
So we, as a college, don't get involved in the contractual detail. This is really the work of the GPC. What I'm hearing is what Amanda has actually been hinting to me for many months, really, that this is a stepping stone contract to the future. I mean, what I see when I look back up till now is a steadily decreasing portion of the NHS budget coming to primary care, and that has got to change. In fact, I was talking to Wes Streeting a couple of weeks ago. He is full of ideas for, if Labour comes in, for really ramping up services in the community, including primary care and general practice. And I said to him, that's all very well, and people have been talking about that for a long time, but the resource hasn't followed the patient. And your challenge, Wes, is going to be how do you make that happen? Because that, I think, is the big, big challenge.
Great, and well done for the first Wes Streeting reference of the day. Okay, well, that was useful, and we might have questions about that later, although, to be fair to Amanda, we can't get into the detail because it's not yet published. But I want to turn now to a different kind of focus, which is around innovation in primary care. As I say, over the last year, I've visited some incredibly innovative practices. And, one of the questions for me is when you look at primary care, it's a highly varied picture. Some parts of the country, it feels that primary care's in a kind of slightly demoralised state. Things feel very difficult. Relationships at place and system aren't fantastic. Other places, incredibly exciting stuff is happening. So, Pram, I just want to start with you. What do you think? What do you think is the kind of secret sauce that leads to people like yourself being able to kind of innovate, think about doing things differently, not just in terms of what you do and how you serve your patients, but how you engage at place and system level?
Yeah, no, thank you, Michael. Matthew, I should say.
That's fine.
Sorry,
Aruna.
Michael. So first of all, I think it's important to recognise, Matthew, that the profession is under strain at the moment. Headspace is limited. But I think when you look around the country, and there are colleagues, I don't know if Neil Mode is here, we've got Sean as well, who's done some amazing stuff in terms of the urgent care space. These guys have a relentless commitment to innovation. But to do that on a continuous basis requires headspace, and it requires time, and it requires leadership. And I think that's ultimately what it requires to sort of start a project. But it also requires resource, and it requires dedication from system partners and leaders as well. So fortunately, in my patch, we have an ICB that is there committed to driving innovation and working with practices on the ground. I think the ICB's role is to create the conditions, okay, for innovative leaders to actually develop those services and then support them. It will go wrong. Teething issues will happen. But it's just how the system leaders support primary care leaders in terms of that innovation and that development and the delivery. In terms of system-wide partners, I think there's a lot of work to happen in terms of the interface piece, and we're going to talk about that later on throughout the day. But we do need to recognise that there has been a shift in demand into primary care. There is a gap in terms of demand and capacity, and I think we need to recognise there will be support required from system leaders and above, and I look at Amanda and colleagues to think about the narrative and the rhetoric around primary care, Matthew. So my point being is, in order to empower our leaders to do the innovation, you do require to sort of give them the support, give them the emotional support, but also the resources.
Great, thank you. And Caroline, I'm interested in your perspective on what it is that enables innovation and change. I was talking to a really innovative Fed a couple of weeks ago, and I said, how is it you brought people into the transformative program you've produced? And they said, we started from convincing GPs that this was going to make their workload more manageable. And that was, until we could demonstrate that, we wouldn't have got by. And it had to feel it was really concrete and really addressing people's immediate pressures, because people didn't have the headspace to take on more unless they felt this was going to help in that way. So I'm interested in your perspective on the conditions that drive change and innovation.
So I'd absolutely agree. I think for GPs, we have felt very overloaded for quite a long time now, and getting worse and worse and worse. And the pressures of the pandemic didn't really help with that. However, we continually see it. So NAPC, I'm fortunate enough to work with some of the most innovative, transformative, imaginative, passionate GPs and people in primary care, but across the whole system for each place that we work. And it's very inspiring to see how so many of us, as you said at the beginning, so many of us actually see these problems as being opportunities for change. Yes, it gets us down and we get fed up, and we all have that negative, those negative times, but we do generally, as a profession, respond by looking to see what we can do differently and how can we actually make things better for our patients, primarily. But what I would also say is that what we believe is the difference is when we've got the conditions are right in a place for the staff, so everybody working in that place to be activated, to feel positive, to feel enabled and empowered and allowed, given permission to actually get on and do things differently. And what you see as soon as those conditions are right, and as soon as people are allowed to just make sometimes very, very small changes. We see on our care programme that we just give permission for people who join the programme to do 2 or 3 patients, do something for them in a different way. And the transformation in the way that they perceive their job just for doing 2 or 3 patients, managing them differently. We've seen a dramatic increase in the retention for those people. They are passionate and excited about their jobs again. They suddenly remember why they went into the profession in the first place, and that joy comes back. And we see that multiplied, when we're working with ICSs, implementing integrated neighbourhood teams on those really wide scales. It's just the same thing. And if we have activated and excited professionals, then we will end up activating and empowering and enabling our patients to do the same. I'm very fortunate. I work in a very forward-thinking, innovative place in Calderdale in West Yorkshire. We are leading the way in terms of the activation space, and we've got so much compelling evidence coming through from all of our PCNs that are all doing different projects at different levels of enthusiasm, different levels of engagement, but all starting to pull together. And the evidence that we're getting through is that if you can activate a patient just by moving them on a little bit so they feel a little bit more able to look after their own health and well-being, that we know that they will then, if you move them by 1 point on a scale, then they will come and see your GP 4 times less in the following year. They'll cost the NHS £327 less in the following year. We know that they're over time, they're over that year, but sustained over time, their BMI drops, they stop smoking, their diabetes rate reduces, their mental health improves, they're better able to manage their finances, their housing improves, their connection improves, everything improves. It's scary how much activating patients makes a difference. And this is not a resource-intensive, expensive, time-consuming thing to do. This is what we as GPs do every day sitting on a room, and everybody in our primary care teams does it. We listen to our patients, we hear what it is that matters to them, and we make a difference to the thing that matters to them, so that when they leave our room, they feel that bit more able to go away and actually look after themselves that bit better. So the big difference that we make is literally that. It's helping people to go away and think, okay, this is not health and well-being, it's not something that's done to me, it's something I have the power and the autonomy to deal with and help myself with. And when they go away able to do that, that's when the magic happens. So for me, this is the big story that we need to be all getting behind. It's about health creation, prevention, activating our patients, but activating ourselves as well, so that we remember why we're in our jobs and we find that joy again and we want to come to work every day, as opposed to where we have been for a long time.
Great, thank you. So panel, I'm going to ask
Can I come in on that a little bit? Just 2 secs.
Of course you can.
Thank you.
How could I possibly say no?
So I agree with everything that's been said so far. I'm not going to repeat that because I know that we've got time pressures. But lots of people are doing amazing work in many different places, and they're all busy reinventing the wheel. And one of the things we need to be able to do is to connect. We need to network better so that people know what's being done somewhere else and think, oh, maybe I could do that. You know, I've come across so much of this. People are often working in their own time. They're really enthusiastic about what they're doing. They can see the benefits. It's what gets them out of bed in the morning. It's fantastic. But it can't go on forever. And we really must find a better way, working together collaboratively to share good practice, enable people who maybe have hit a brick wall to phone somebody or email somebody and say, you're doing something really similar to me. How did you get around this or that problem? And I think that's a really important thing. That's something. I think that's a take-home message that we should be taking home from today.
Thank you. Okay, so panel, I'm going to ask you a couple of questions and ask each of you to respond. So don't feel the need to kind of repeat what other people say as we go along. We'll see whether there's difference or consensus. So, Amanda, I'll start with you. You talked a lot about access, and we were talking a lot about access last year. But I've seen Claire Fuller give presentations in which she's also pointed out that continuity is something which really matters to people. So when it comes to the public as a whole and the media, access, but when you actually talk to patients about what matters to them and gives them the greatest satisfaction, it's notions of kind of continuity. And of course that then feeds into the Fuller agenda, and we've started to see some systems, North West London most obviously, doing some quite radical things in that kind of space. So where do you think we are with that agenda right now? And are there ways that we're thinking about this that aren't quite right or need to change? Or is it really just about pushing ahead with that Fuller agenda?
So I think continuity is really, really important. I've spent many, many years as a partner in a GP practice, and it's not only important to patients and their outcomes, it's actually important to GPs. It makes it easier to do your job. So it is really important. I've been really conscious since I've been in this post, which is probably about 18 months, not to push unrealistic expectations of what people can deliver when it's clear that demand outstrips capacity by as much as it does at the moment. So I think continuity is really, really important. I think continuity, being able to offer continuity, is partly a function of capacity. So the reasons often we fall down around continuity is we don't have the capacity to meet everybody's asks all the time, and so people end up being slotted in where they can and not necessarily with the person who knows them or the team who knows them. And so we've got to almost do both at the same time. If we can't increase capacity, it will be really hard to tackle that. We are looking at ways in which in the future we can recognise in the contract the importance of practices focusing on continuity without introducing silly measures and boxes to tick and things like that. So we are looking at that. As far as the changes that are being put in place, it's really hard to resist ploughing in and interfering with stuff, if you're like me. But I really want to give local PCNs, but also systems, the space to try solutions and see if they work. And I am conscious that 2 or 3 systems are doing this sort of thing. It's what they're all doing is slightly different, and so it's actually quite a good opportunity to see what works. The test will be whether patients like it. Continuity is really important, but I haven't got that much of a problem with places that are saying we'll just filter out the ingrowing toenails and the quick, very one-off things. and support practices to get them seen in an organised manner at scale. If it became something that said everybody's being dealt with at a scale where it becomes hard to offer continuity properly, then that would become apparent very quickly, and then that would be something that would make me more nervous. But I'm really keen to just step back and see how these things work. And the best test of how well they work will be how satisfied patients and practices are with what happens.
Great, thank you. Samira?
Thank you. So, yeah, we completely agree on the continuity of care argument, really important in terms of improving outcomes, in terms of reducing healthcare usage, and given the pressures around demand, that's a really, really key element. And I just want to actually echo, I think, Camilla and Caroline's points around the innovation. So we know that there are some practices that are actually delivering longer appointments versus that access pressure, you know, versus the number. And actually their patients are much happier, their outcomes are better, they're having reduced visits. But that really takes a safe space, a confidence and an ability to say, actually, we're going to do this and we're going to try and do that. We're not in that space at the moment where we're able to sort of experiment so much without the fear, I suppose, of, you know, losing the appointments. But I think it's really positive that that's the direction that we're going in. It's really important that we really keep a focus on why we're doing this. I think the patient is the centre. So it's the holistic care, it's the continuity care, it's knowing them. And as we know, all of us working in general practice and primary care, someone may come in with a very minor issue, but actually reveal something far greater. So how do we know that we're not missing those icebergs? How do we know that we're not actually having a cumulative effect? And I think we don't know yet, that's the point. But actually it's really exciting that there's a lot of research that's been done. We actually shared the Dennis Pereira-Gray paper on continuity of care and how it was important. And I think we're all in that same direction. We don't know yet what the roadmap is. And one thing I'd just say, I am an acute trust, I'm the place-based care lead. But with that hat and with others, I would just say that the outcomes and the KPIs are really key. This is not about reducing ED attendance, because if you read the North West London paperwork that accompanied it, those case studies looked at reduction at ED. This is about the patient, their journey, their experience, and their health. And I think given those financial constraints that we're under, very understandable with the deficits, that might be quite seductive, but I think we really need to be quite strong and resolute in really being key, what's driving it, what we're monitoring, and what outcomes are going to guide us to where we need to and why.
Caroline?
So I absolutely agree with what's been said, but I think let's sort of take an example. So you could deal with this particular patient in a different way. So if we've got a middle-aged man who's presenting with hip pain, that's what he says he's got, you know, he's got hip pain. If you've got somebody who hasn't got time, has never met him before, they will treat the hip pain, and probably he'll end up referred for a total hip replacement. He'll sit on a waiting list for quite a long time. But he will be under the misapprehension that his life will improve when he has his hip replacement and that suddenly everything will be cured. Actually, what will happen is he smokes, he's overweight, he doesn't ever do any exercise, he drives for a living. You know, he will have a lot of complications when he finally does get to the top of the waiting list. He'll have his hip replaced and he'll find that he's no happier with his life anyway, because that wasn't the problem, because nobody listened probably to him in the first place. We didn't have the time. If you have an experienced GP who can sit and take the time to listen and speak to and assess that man correctly, we will realise that the hip pain is a symptom of all the other things that are not right in his life. And we will help him to go and see the social prescribing worker, go and see the physio, connect with the local walking group or the walking football group or whatever it is. And he will hopefully stop smoking, lose some weight, get a bit of exercise, start to connect with other people in his community, which he hasn't done because he's driving and he's never able to do that. And he probably will never even get listed for his hip replacement. But if he does, he won't end up with the complications. And he will actually be happier. He'll be happier immediately, even just from having that conversation, because there's something he can do about his life. And we can support him as a team to do that. But it takes that little bit of time. And, you know, ideally, we've met him before. So I think that's the benefit for me.
Great. Camilla?
So as you come to the end of the line, there's less and less to say, so that's good.
I'm going to start from the other end next time.
But, you know, when you look at the access continuity conundrum, the problem is capacity, isn't it? And we don't have enough GPs who are able to give that kind of holistic care that Caroline's talking about. And I think that, what we really should be thinking about here, in addition to access versus continuity, which is what we do to deal with the now, but we need to be thinking about the near future and the mid future, as well as the future, which is about how do we retain GPs. And we've been really worried in the college to hear that the new to practice fellowship money and the mentoring monies are now going to be probably divided amongst the ICBs to be handed out locally. We really worry as to how that's going to be protected, that funding, whether or not retention is actually going to get the focus that it really needs, and it desperately needs it. We know that new to practice fellowships, 8 out of 10 of these new to practice fellows say that it's helped to keep them in practices, and that they find it really helpful to the beginning of their careers as GPs. So I think we mustn't lose sight of the fact that retention is a really serious issue for general practice.
Thank you. Pramit?
So again, I'm not going to repeat what everyone said. However, I think there's something to be said about the operating model, Matthew. And I think it's just understanding exactly how can we start addressing demand failure, because demand doesn't equal activity. Okay, I think we've got to be really clear. We can sometimes over-generate activity through not efficient operating models at all of our levels, so be that general practice, PCN and above. So I think there's something about us looking at all of our operating models and working out, is there an alignment? But that also requires conditions, Matthew. So at the moment, when it comes to access, if you call 111, you go to A&E, you go to your general practice, or you go to your minor injuries unit, you may have 4 or 5 different outcomes. And some of that comes down to the contracting piece. So 111 providers have to use NHS pathways, we don't. So how can you have different contracting mechanisms trying to address the same thing? So I think there's something for all of us, our ICBs, our providers, working hand in glove, understanding how do we create alignment, how do we create continuity? And therein lies the opportunity. We can create capacity by reducing demand failure, but it requires all of us to actually work together.
Thank you. I've got a perspective on this. Can I? I'm chair. I'll only do it for like a minute. Amanda's given me a look. Looking across the whole of the health service as we do at the Confed, I've come to the conclusion that one of the challenges or opportunity, I don't know what it is that there are 2 very different models of thinking about health and care. One is a kind of industrial medical model, and that's kind of, DHSE, NHSE, regions, ICBs, trusts, primary care in terms of the kind of national targets. And then there's a kind of social system model, which thinks about health more holistically, ICPs, places, neighbourhoods. And they're very different, these models. So the first one focuses on organisation, the second one focuses on places. The first one focuses on kind of management hierarchy and its effectiveness. The second one focuses on collaboration and work between organisations. But the other thing that's really interesting about these 2 paradigms is that in the industrial medical model, the problem with the public is demand. And how do you deal with demand? Whereas in the social system model, the challenge is engagement, which is, to your point, Karen, actually, in order to ultimately have a sustainable system, we have to engage the public much more richly, not just see them as a problem because they've got too many demands for us to manage. And I think that these 2 paradigms, they really meet in primary care in terms of the different kinds of pressures, the different way we see our work. That's the only thing I'm going to say of any substance. Right. But from that comes another question I'll ask the whole panel. And then I'm going to ask you to ask questions. And the reason I'm doing that is because I've got an iPad here with the carefully curated Slido questions, but I've left it too long. And so now I've got a photograph of someone's wedding, which is really nice, but I can't get access to any of the questions. So, no, it's fine. It's fine. It looks like a lovely wedding, by the way. Not your wedding. Oh, you've just got someone else's wedding. Oh. But you can't ask really detailed questions about the contract, folks, okay? And please be positive in your questions and short and sharp. So what I'll do is I'll ask this question and I'll take 3 or 4 questions from the floor and then come back to you. Okay, so the question, again, I want to ask our panel is just about kind of capabilities. And I'm thinking here not just of GPs, but of the whole kind of primary care sector. So there's kind of 2 elements to this. The first is that clearly one of the challenges, one of the differences, as I go around the country looking at primary care, is around leadership and the capacity of primary care to work together to have a strong voice at system or at place level. And it is highly variable. In some places, primary care is really well organised, got a really strong voice. Other places, I mean, I remember talking to a place leader a few months ago and said, my GPs are split into two camps. If I talk to one camp, the other camp won't talk to me, and it's quite challenging. So one is the leadership element, and we've got the emergence of primary collaboratives as one kind of part of that, and that's leadership capacity. But at the other end, we're doing a lot of work in the Confed around integrated neighbourhood working, and there the challenge is engaging with communities, which can be a really messy business. Communities don't necessarily say the things you want them to say. That's new work for us as well in many ways, that kind of really deep engagement. So starting with you, primary, these questions of the core capabilities we now need in primary care, it is shifting, and are we investing enough in developing those capabilities?
Short and sweet answer, no.
Okay, thank you.
So we're not. So in terms of is there investment required to actually develop those capabilities? Yes. However, there is a bit of time that is required in terms of understanding what is the vision, what are we trying to create, and therefore making sure we've got leaders at every single level, and there needs to be communication, there needs to be relationships, and there needs to be engagement. And I suppose, but back to your point, Matthew, there is something about folk staying in their lanes and doing things that they understand well and doing it well and executing it well. We have to be, there is a bit about, you don't want to be the master of none and the jack of all trades. You've got to try and make sure you do things well. So there is a bit about how do the healthcare providers within your PCNs work together, be that your general practitioner, your community providers, your pharmacists, your optoms and your dentists. I think we need to be clearer about the seamless healthcare pathways and how we interface with our organisations within our integrated neighbourhood geographies. And I think that comes down to the ways of working. So if we get ourselves together and sort ourselves out, organise ourselves in a proper, sophisticated, seamless, futuristic way, how we then interface with our wider organisations becomes a lot clearer, and it becomes clearer for our public as well. Because the public don't know who to go to and when to go to. So we need to make it really clear for them what works for them will work for us and vice versa.
Great, thank you. So Camilla, not just effective clinicians, but community activists, organisational leaders, these are new challenges.
Yeah, they are, and they won't suit everybody, of course, just as Pramit was saying. But if I can give you an academic medical educationist response to this,
Great.
It needs to start in medical schools, and it does already. There are most medical schools, I would say, now have a vertical theme of leadership and management, not just leadership. Then it needs to come out, I always think that the foundation years are a lost tribe actually, but it needs to come out in foundation years and then on into GP training. Now the trouble with GP training is that it's only 3 years long. We've been asking forever for it to be extended, but there's really no sign and no sign at all of the door opening even a fraction of an inch. And this is why I'm going to bang on again about the New to Practice fellowships, because those are an opportunity for people to spend another couple of years actually becoming the GPs they want to become. And in a way, it's like a 3+2, 3 years of GP training followed by 2 years of a fellowship. There you are, you've got your 5 years, and a chance to develop yourself as a GP with a special interest perhaps, learning how practices function, learning the leadership at the partnership level, and then from that, learning the leadership with how you communicate with other people. I've been a community activist, but I've had to learn the hard way. It's taken me 30 years. I don't think it should take that long. You can do it much quicker than that.
Yeah. And by the way, this isn't just about GP, it is a broader primary care team. I was reading a King's Fund report about the future of dentistry that emphasised that part of the solution has to be a model of dentistry that's more involved in outreach and engagement with the community, for example. So these are issues across the piece. Caroline, what's your kind of perspective on this?
So I think at NAPC we've been working in this space for a very long time. Primary care homes came from NAPC, which developed into PCNs, probably a different thing because it was a contract, but at least it was still bringing us together as localities. But the whole point of primary care homes and what we now work is with developing integrated neighbourhood teams with lots of different places around the country it's about everybody who's in that neighbourhood or in that locality, whatever you want to describe it, working together, and the leaders are there. They're just different people in different parts of the country and in different places, and even neighbouring places, they're different people. So you might have a pharmacist that's leading it in one place or a physio that's leading it in another. We had somebody from the fire service that was really proactive, somebody else from public health in Calderdale that was really leading all of these things. So there are leaders there, and they're often within the community, but we need to create the right conditions for them to work. And what we find at NAPC, and this is particularly true with the integrated neighbourhood teams piece, is that when we go to a place, so somebody will have invited us in the first place. So we've been invited in, so there's somebody there, whether it's the Accruit Trust or the Mental Health Trust, a GP, somebody has recognised the potential to do something differently. And what they usually want to do is they want to invest in changing something, putting in inverted commas, integrated neighbourhood teams. And what we have encouraged and found to be very, very true is that the first thing we need to do is make sure everybody's on the same page. So we talk to everybody. And actually everybody, we all want to do the same things. We all want to innovate. We all want to change. It's just we all at different points in that journey. And so when we talk to people, sometimes it needs individual conversations, sometimes it's group conversations. But when we help people to form those relationships within their patches across the whole wider system, then that's when the magic starts to happen. And that's what we think at NAPC is the secret, is let's all actually make sure that we're on the same starting page, and we can encourage people to and coach them into those leadership roles when they didn't even realise they were a leader. And we've certainly seen that happening in my patch in Calderdale, but we've seen it happening in Dorset, we've seen it happening all over the country. And it's exciting to see how you can, with relatively little interference and resource, actually explode change and innovation.
Great, thank you. Samira.
Thanks. So I was very lucky, actually. I was just thinking, reflecting personally, when I qualified, a CCG neighbourhood lead role came up, and within 2 months I was able to take on this role, which is, I think, quite unusual for newly qualified GPs. I got to chair meetings across the city, and yes, Camilla, practices on the next road might not know what the others are doing, and that's what these meetings actually revealed that. But what was really key, and I think Matthew, when you were talking about the social determinants of health and the social model, so if you look at it, it's 90%. And then what's happened, I think, over recent years, we've medicalised it. What was really key in the neighbourhood teams is that they linked in with the local authority. So you had a social worker, you had data looking at, for example, any police incidents, schooling, health visitors. So health is the whole context and well-being. And I think, therefore, it's not, again, about the siloed, this is your GP, this is the NHS bit, and then we forget about everything else. Given the financial constraints, we really need to look at it across the whole system. And then the other things around the interface, I think it's the permission, but also the resourcing and the workload. I think historically, in one patch, if you've done something, those savings may be realised elsewhere, and therefore that might have acted as a disincentive. Obviously, with the move to ICSs, the idea is that we're more integrated and working across the whole system. But I think making that a lot clearer, and actually for people, people are motivated by different things, and we have to really recognise that. The drivers are making that more explicit. And Camilla, I completely agree with you. We tried to speak to our local patches about engaging in terms of leadership and around the LMC. So, and we were told only high flyers. However, in primary care and in the health service, you will be expected to lead, whether it's in your own patch or across the system. And it's really important that that starts, whatever role you're in, really at the beginning, to give you that opportunity, but also that confidence to then create those opportunities. Because if you're fearful, you might have some fantastic ideas, but feel that you can't take them forward. So I think it is key. And I think, we would totally support you with the fellowships, because it's kept people in, newly qualified, who, from practitioner health data, a few years back, were suffering massive burnout. So we have to think about the well-being of our workforce, how we can keep them in, but also get those benefits longer term.
Okay, Amanda.
So I think it's worth acknowledging that leadership in a primary care environment is really hard. So if you work in an acute trust and you're a clinical director or a medical director, it's your job to lead. And you've got a degree of authority that gives you that sits alongside the leadership role. So it becomes much clearer about what you're expected to do and ways in which you can do it. It's really difficult in primary care, where a lot of it is much more about consensus and people allowing you to lead. And there's a huge disparity. Well, you can lead your PCN, but this person's leading the place and this person's leading in the ICS, and we all say different things, and the LMC's leading this, and it's really, really difficult to do. So if I could ask one thing, it is that primary care, and not just general practice, but all of primary care, works to achieve enough consensus to support leaders so that primary care has a voice. Because what you get if you get either completely disparate leadership or no formally acknowledged leadership, you just don't have a voice. And one of the challenges we've got is it's really, really important that we up the voice, not only of primary care, but of community and primary services as a whole in the wider system, because otherwise we just get drowned out. And this leads to the problems we've had over the years of being seen as a less important voice than some of the big providers are. So I would urge people to think really systematically about not only who the leaders are, but supporting them and giving people the space to actually go out and do this. It's really, really important. And we're hearing it a lot from people with frustration about how do we get the primary care voice into our ICB's decision making or other environments. Can I just pick up the bit about integrated neighbourhood teams? So I don't think they're a thing. I think they're a way of working. They're a way of working between the general practice, community pharmacy, other primary care providers in a place or a neighbourhood, and the community service teams and voluntary sector and others that they work with. But we've got to switch from it's a thing, let us know when you've found one and put it in place, to how are we working locally in a way that means we function as an integrated team. And some of that is going to have to be acknowledging that any really functional team needs a way of working which acknowledges leadership and not I'll lead the pharmacist and I'll lead community nursing and I'll lead the voluntary sector and I'll lead the PCN. So there's a lot of work to do in this space.
Great.
I won't talk about fellowships unless anyone explicitly asks me, but
okay.
Yeah.
So we're eating into your coffee break. Pramit wants to say something, but you're just going to smuggle what you want to say into an answer to the questions we're going to get. We, by the way, talk about integrated neighbourhood. We've got a session on this later on. So we think it's better to talk about integrated neighbourhood working rather than integrated neighbourhood teams in our kind of leadership development offer that we have as well. You know, just because NAPC is obviously wonderful, but we have our own offers, and you know, I'm sure there are other brands available. Anyway, so I want to take 3 incredibly quick questions from around the room, and there's a hand. And is there a mic coming down to you? There is. And there's a hand, and that's 2 blokes, so I want to see a woman. And there's a woman over there. Brilliant. I'm like an auctioneer here. Really, really quick.
Hi there. My question is actually...
Tell us who you are.
My question would be probably to Amanda.
No, just tell us who you are.
Hi. I'm Dr. Amadi. I'm a GP from Ipswich, Bliss PCN. Now, my question is actually, you know, obviously, as a GP, in order for us to have a holistic approach and, you know, a headspace and have a leadership to apply our leadership skills, obviously, we need some support with demand. We do our best to actually, you know, to optimize and actually create less demand and empower patients. But I just wonder, what is it the NHS is doing in order to actually reduce patient demand? Whereas when you see the drivers always just to increase that demand. Well, I'll give one example of actually...
Briefly, if you could.
During COVID, we actually, all cough and cold and sore throat were actually, because we had the government support, all of this was actually, patient never contacted us for that. But now, if you look at this, 30% of our contact is actually the cough and cold. Even if you call 111, the outcome is contact your GP with a sore throat. And I think, that needs to be a government level, approach to actually adopt that 111 national, pathway, or maybe perhaps, do a lot more with the media, a lot more with that, to get patient to actually, it's not, if you got cough and cold, sore throat, you don't need a GP, then it gives us a lot of head space.
Great, thank you. How can we tell the public to pull their socks up a bit more often? I mean, it's a much more sophisticated question, that, but there is something about public messaging, the social contract and all of that kind of stuff. Yes, there. Yes.
I've heard 5 amazing GPs talk about primary care and talk about general practice, but actually, how do we try up the voice of community pharmacy? Because guess what? We create capacity. Guess what? We provide continuity of care. All the things you've talked about, we do, and I'm sitting here in the corner feeling slightly frustrated and want some really positive solutions from those 5 GPs.
Thank you very
Can I
much. A
pick
really good point.
those up at the
No,
same
just there's going to be
time?
one more question, and then what you're going to do, panel, is just pick one point from those questions to respond to. That's all you're going to do. Okay.
I'm Bren. I volunteer in my local community and I've done for just over 2 decades, really, an area of greater need, not an area of deprivation. So I learned a lot from the panel, really, but I come across a number of my friends who are phenomenal leaders, and they're doing great work despite the system. And they're doing it in the way they're comfortable with and the way the communities are comfortable. Going back to your point about the social model. So how do we educate our leaders better to actually leave that alone, let it develop, let it grow, and choose to support it when we're invited? Thank you.
Great. Well, really varied question. So, panel, this is what you've got to do, and you've got less than a minute to do it each. We've got 5 minutes left. That's 1 minute each. You've got to choose one of those points you want to respond to, and you've got to give us a message of hope to leave the room with. And I know, Pram, you want to respond to about 14 other points as well, but you've only got a minute, and your minute starts now.
Thanks very much, Matthew. So, Rena, you're absolutely right. We have to think about our descriptions when we're talking about primary care, and we've got to give our P and our O's and our D's the airtime. And I think in our own system, that's exactly what we're doing. We've engaged with our pharmacists, our optoms and our dentists in a forum, and that channel, that message funnels through our directorate, into our partner member, onto the board. You need to make sure it comes down to ways of working, but you also need to land your governance.
Respect to the pod. Right, Camilla.
Okay, I'm going to answer 2 in 1 minute. Rena, you should be sitting in my chair next time. Okay, that's my solution there. And as for you, sir, yes, the way we do it is by sharing good practice so that other people learn, because otherwise they won't.
Very good. Okay, you're all beating your time. It's fantastic. Caroline.
So I think it's about activation. We are activating our community pharmacists at the minute through Pharmacy First, and that's to me a stepping stone along the way to empowering and helping and working with our pharmacists to get them to be doing the health creation and activating patients, because they see more of them than we do. And similarly, working with our voluntary sector is equally important because they know how to activate patients. That's what they do, and we need to help them to be able to do that more for our patients. We can work smarter, not harder, if we work collectively.
Fantastic. Samira.
Thanks. So, Rena, I was just thinking, I think in general practice, and the reason I talk about general practice is because I'm a GP and I work in general practice. I'm a PCN-CD as well, but I wouldn't want to say that I am your voice or replacing your voice. It's really important that we have an MDT team within general practice, within primary care, and that we work collectively, respectfully, with parity of esteem across, and that goes without saying. So I think that's really crucial, and we do have those engagements because we bring different expertise. In terms of the other bits, I think we were talking about, people have mentioned agency, autonomy, self-determination, and I think, and empowering people, and I think that's the key thing. That whether you are working at, I don't know, on reception or, as a GP, those similar principles are really key to making people happy, feel valued. And again, I think it goes back to community assets. So a GP practice in one corner of the road might have a very different community feel, their patient population, and it's respecting that and using that skills and asset-based approach to really harness those benefits rather than dictating, again, saying this is how you do it. So I think, again, it's being very respectful and having that parity of esteem, that there are benefits, again, with the social determinants, which is really key, given we're in a resource-restricted environment with lots of financial pressures. Sorry, it probably
That's
took more
great,
than a minute.
perfect. Amanda, last but not least, and I want you to respond to the demand point
I'm going
as
to
well.
respond.
Can I just, before you do, I'm a parent. I have children who go to school. The requirements that a school makes of me as a parent are pretty extensive, but we don't have that same kind of robustness in terms of our relationship with the public. Now, I'm not saying it's easy to imagine how you do that, but this point about our messages to the public, we know that during COVID the public behaved differently. We know that during industrial action or the early days the public behaved differently. Do we need to be doing more to shape public expectations around demand? So do respond to that point, but then say anything else you need to. And you've got actually 1 minute and 27 seconds.
Thank you. So I get that demand is huge, and I get that there is a large volume of work that is not serious, except for the very few of those that are serious, and that's the challenge we've got. You cannot say we are not seeing sore throats, because a very, very tiny proportion of people who present with a sore throat have something seriously wrong with them or need treatment. A much bigger proportion, or a substantial proportion, need antibiotics. But we have recognised that there are high volume but generally low complexity conditions that present to general practice. And that was what drove the thinking around Pharmacy First. And we recognise that community pharmacy is a huge untapped pool of clinical capability. And we have traditionally made it a service that dispenses tablets with a little bit of clinical service provision on the side. What I want to do, and Pharmacy First is the first step in that, and Pharmacy First is a big thing. It's £600 million of investment in community pharmacy. I want to move from community pharmacy being a clinical service provider as part of the offer in a neighbourhood or in the community to people, with some increasingly automated dispensing of tablets on the side. And that's the aim. 2026, all graduate pharmacists will be independent prescribers. That is a game changer for general practice as well as for community pharmacy. And Pharmacy First, we've talked a lot about the 7 common conditions, and we're just about launching a media campaign, starring Rima in fact, for the public, telling them what they can do. We only launched it 3 weeks ago. We didn't want to go out on day one and have half the population going to be fair, 95% of pharmacies have signed up. So we're launching a campaign, we're pushing the message about what people can do. But what we really need to do is, we've really stepped up blood pressure identification and assessment through community pharmacy. It's a game changer if that community pharmacy can also help up-titrate medication, be part of the routine monitoring of uncomplicated hypertensive patients, of whom there are huge numbers. The oral contraception, you can not only get a repeat prescription for the pill, you can go and have initiation of oral contraception. Huge numbers of people who tend to be young, fit, and want easy access to the things they need. Again, Pharmacy First, really high volume but low complexity conditions, sitting alongside the existing minor ailments service, which is a sort of mishmash of other stuff. We really see community pharmacy as a big part of the future of clinical service provision, and don't want to be distracted by it's all about just picking your medication up, and if you happen to get a vaccine while you're there, it's fine. So if you want to give me another hour, I want to talk about dentistry as well as community pharmacy, because they and community services are all part of my portfolio and all part of the solution. This is not about just tweaking things for general practice until a miracle occurs.
Absolutely understood. Pramit's on my board and has insisted that he makes the last point, but it's got to be less than 20 seconds.
The clock is flashing in front of us. So something about leadership, Matthew, okay, and in systems. Now, we have gone from a GP, apologies to non-GPs, a GP-led organisation, CCGs, into a wider, more integrated leadership board. But there is a lot of focus now on trust provider collaboratives or acute collaboratives. And I think we need to think about the opportunities in terms of how do we then organise ourselves and think about the primary care collaboratives. And I think, Matthew, for me, that's where Confed really plays a role in terms of defining what the primary care collaborative voice could be, what it should be, and what it can then do to make sure our voice is actually held right to the top.
How better to end than but for an advertisement for the fantastic NHS Confederation. Okay, can I ask you to finish by thanking our fantastic panel? Thank you.
Clap for you.